हा आता युट्यूबला स्ट्रीमिंग होते. हा करू शकता सर.
A very good morning to all delegates. Thank you for joining us for today's webinar. Myself, Dr. Meenakshi Singh. It gives me immense pleasure to extend to you a very warm welcome on behalf of Dr. G.D. Pol Foundation, Yerla Ayurvedic Medical College, Prasuti Tantra and Stri Rog Department, who has clubbed all of us together. Let's start this session with Dhanvantari Stavan. I request Dr. Pooja to please start with Dhanvantari Stavan.
यो विश्वं वेदधाति पाति सततं संहारयत्यञ्जसा सृष्ट्वा दिव्यमहौषधीश विविधान् दूरीकरोत्यामयान् बिभ्राणोऽञ्जलिना चकास्ति भुवने पीयूषपूर्णम् Now, I request Dr. Seema Mehere ma'am, HOD and Professor of Prasuti Tantra and Stri Rog Department to welcome our dignitaries and delegates for the session.
Thank you very much, Pooja. It is a great morning and I welcome you all with great pleasure for this national webinar on Ayurvedic aspect of colposcopy. And of course, I welcome my dear madam and colleague, Dr. Vishala ma'am. And thank you in advance only for coming to our session. I welcome our honorary chairman, sir, Dr. G.D. Pol, sir. He is our inspiration and always been there for us. So without his name, we cannot, go forward. And then I welcome our dean, sir, Dr. Sanjeev Yadav, sir. He is also a big motivation and inspiration for us. Then I welcome Dr. Ninad Sathe, sir, vice dean of our college. Dr. Zaikini madam, PG coordinator, and always a very helpful personality. She is always there for us in all our activities. And most of all, I welcome the delegates who have taken time to register and log in for today's webinar. I thank my colleagues, all the HODs of our college, and of course, all the HODs in our fraternity who have taken time for this very innovative and timely webinar. We all felt this topic is very important because for generation next, we have to, tell them that what is Ayurveda once again. So, and whatever new, actually colposcopy is also not new. It has been in the wings, I will say, for a long time. But now it has come in the forefront. It is a frontliner now because of the higher incidence of CA everywhere. And you all know that the best thing of cervical cancer is that it can be cured very easily. So that is the reason why we thought of taking this seminar. And of course, our generation next and our colleagues, everyone should know what Ayurveda has for it. This also coincided with our program of Har Ghar Ayurveda, which the Ayush has declared till 23rd October. And we would like to actually, encourage all our PG students, UG students, all our PhD students, fellowship students who are, I welcome them also, who are joined today. And they should spread this message that Ayurveda has a lot of things going for them. And in fact, we have an upper age, if you go to see, that just last some 20-25 years ago, when we started our graduation on all, Ayurveda was not so much in the forefront. So today's generation is really lucky. And once again, I welcome all of you. My colleagues, of course, my departmental faculty, Jenny Madam, Nishigandha Madam, Mayura, Mangesh Patil Sir, Pranali Madam, all my PGs, all are welcome. And without taking much time, I will hand over the mic to Dr. Meenakshi, and she will continue the session. Thank you so much. Welcome again.
Thank you, ma'am. Now I request Dr. Nishigandha Pol, ma'am, Assistant Professor of Prasuti Tantra and Stri Department, to give brief introduction of our institution. Please, ma'am.
Good morning, all. I am Dr. Nishigandha Pol, Assistant Professor in Department of Prasuti Tantra and Stri Roga of Dr. G.D. Pol Foundation, YMT Ayurvedic Medical College and Hospital, Kharghar. Dr. G.D. Pol Foundation, earlier known as the Irla Medical Trust, was established in 1989. What started as a humble journey from Curry Road, Mumbai, a small hospital, has today flourished into a plethora of educational institutes and colleges under same banner. Dr. G.D. Pol Sir's vision and quest for the excellence in all educational fields has led to establishment of renowned educational institutions offering 9 courses, namely UG and PG in Ayurveda, homeopathy, and dental, as well as nursing, physiotherapy, and optometry. It is increasingly being recognized as a provider of quality education in Navi Mumbai. Our chairman, Dr. G.D. Pol Sir, believes in providing quality healthcare services to the mankind, the best medical education for the students, and advanced medical care at a minimum cost. As a result of which, today, all colleges under our banner are working 24/7 in the pandemic situation and throughout the lockdown period also. Even on the digital platform, we are making our presence through webinar, and we are active on social media too. YMT Ayurvedic Medical College has 270-bedded, well-equipped hospital with OT facility, and we are following the guidelines set by Ministry of Ayush as well as ICMR as per treating the patient and providing healthcare services. In the past, our college had set up a Limca book of records. 290 live anorectal surgeries were performed in a single day. Also, National Conference Ayur Kaushalya, which was organized in 2017, and recently we had organized World Ayush Expo 2019 in collaboration with Ministry of Ayush, which was another feather in our cap, with 3,000 beneficiaries and delegates who attend our conference not from India but all over the world. Now coming to our department, we have full-time staff of 6 teachers, in which include our HOD and Professor Dr. Seema Mehere ma'am, our associate professors Dr. Mangesh Patil sir and Dr. Pranali Dandekar ma'am, and assistant professors Dr. Mayura Devadiga ma'am, Dr. Jenny Bhatt ma'am, and myself Dr. Nishigandha Pol. In our department, we treat various gynec disorders as well as antenatal and postnatal care. Our specialties are treating infertility, PCOD, Ayurvedic Garbha Sanskar, and Panchakarma treatment on various diseases. Also, we have seats for post-graduation, PhD, and fellowship courses. Our department also works on various research projects approved by MHS. In the corona pandemic situation, we had arranged national webinar on COVID care in obstetrics. And today, we gather here for another webinar for updating our knowledge on colposcopy. Thank you very much for a patient hearing. And now I hand over the mic to Dr. Pooja for further proceedings.
Thank you, ma'am. Our today's speaker for the session is Dr. Vishala Turlapati. I request Dr. Mayura Devadiga, ma'am, Assistant Professor of Prasuti Tantra and Stri Roga Department, to introduce our guest speaker. Over to you, Mayura, ma'am.
Namaste and good morning to one and all. Myself, Dr. Mayura and Devadina, Assistant Professor in YMT Medical Hospital. I am very much pleased to introduce Dr. Vishala Tullapati Madam, today's our guest speaker on this occasion. Madam, Dr. Vishala Tullapati, she is MD in Prasuti Tantra and Kriro, and she has achieved her PhD in Commerce from National Institute of Ayurveda, Jaipur. Presently, she is working as Professor and HOD in Prasuti Tantra Department at Yeshwant Ayurvedic Medical College and PG Center, Kodoli, Kolhapur, Maharashtra. Madam has a vast academic and clinical experience of 25 years. She is a certified colposcopic since 2013. She has 18 research publications in peer-reviewed index journals. Some of her research paper presentations are as follows. She has presented a paper on Cervical in female at Bharatiya Chikitsa Darshan National Seminar on Panchakarma at Bellary in 1997. She was a guest speaker, delivered lecture on Cervical at Reorientation Training Program on Panchakarma conducted at Saranath Government Agricultural College, Bellary, sponsored by Ministry of Health and Family Welfare, Government of India in 1998. Madam was also the guest speaker on infertility, a critical analysis and management in Ayurveda, a CNE program conducted by AMAI Bellary state level. She was the guest speaker and delivered lecture on endometriosis and treatment modalities in state level postgraduate conference of Prasuti Tantra and Kriro at SDM Ayurvedic Medical College, Udupi in 2004. She was also the guest speaker delivering lecture on uniursals and its effect on fertility in national workshop on ursals at SDM Ayurvedic College, Hassan in 2004. She has submitted scientific paper on dietetic protocol during antenatal and postnatal period at National Seminar on historical aspects of diet at National Institute of Nutrition, Hyderabad, which was sponsored by CCRS in 2006. She was also the guest speaker in Germany in 2014 National Conference on Preconceptional, Antenatal and Postnatal Care, sponsored by the Department of Ayush, Government of India at Braga Keli Ayurvedic Mahavidyalaya. She has presented a paper on recurrent pregnancy loss in National Seminar on Infertility at Pune, organized by BabyQ 2015, which is a national conference event. Madam has completed a colposcopic training at the FOXY. Presently, she is working on colposcopic evaluation of cervix and cervical cancer screening with management of premalignant lesions by Ayurvedic system at Yeshwant Ayurvedic College. So we are very much eager to hear Dr. Vishala Tullapati Madam for her extensive work in this field and her experiences which she is going to share with us. We welcome you heartily, Dr. Vishala ma'am, and now I ask Pooja to continue with the session.
Thank you, ma'am. We are going to start our lecture. So I request all delegates to put your queries in the comment box, which will be discussed at the end of the session. Now I invite Dr. Vishala ma'am to start today's lecture and guide us for the same.
Thank you, Dr. Pooja. Thank you, Dr. Pooja. Good morning, everyone. And on this outset, I would like to express my sincere gratitude to Dr. G.D. Paul Foundation, YMT, Mumbai, President Dr. G.D. Paul, sir, for considering me to share some of my views in this webinar, and also Honorable Dean, G.D. Paul Foundation College, and the HOD, Dr. Seema Mehere Madam, and the associates and assistant professors of the department, and all the PG scholars of the YMT College. My sincere thanks to each and everyone for giving me this opportunity. And I would also like to express my sincere gratitude to my esteemed institute, Yeshwant Ayurvedic College, Kodoli, and our Honorable Secretary, Dr. Jain Patil, sir, Yeshwant Shikshan Prasharak Mandal, and our Honorable Dean, sir, Dr. M.M. Godbole, sir, to allowing me to work on this subject and also to give me the permission to participate in this webinar. I'm really thankful to all my institute, my department colleagues, my PG scholars, everyone who is taking part in this noble program of detecting the pre-malignant lesions and giving a contribution from the Ayurvedic science, whatever the help we can do to the community. So with this, I'm going to start my lecture. So shall I share the screen?
Yes, ma'am, you can share your screen.
Yeah.
I've made you the co-host. You can share your PPT, ma'am.
Yeah. So is it visible now?
Yes, ma'am, it's visible.
Yeah. So the topic is colposcopic evaluation of cervical lesions and the scope of Ayurvedic intervention. On this outset, I would like to express my sincere gratitude and very humble, what you call, say, the greetings to Dr. Radhika Joshi, Madam, Yashomangal Clinic, Kolhapur, who is a pioneer in training the non-FOXY people like us in this colposcopy, because we are not the FOXY members, but still Madam is so generous to extend her training program to the enthusiastic people. This center is located in Kolhapur, so I'm really thankful to Madam for making me to learn this colposcopy. There are many people we have to remember on this outset, like Dr. Usha Saraya, Dr. Purandare sir, the ex-presidents of FOXY, who were behind this colposcopic evaluation of the cervical lesions. So the main intention of this program is to save the uterus, to say frankly, because there is a tendency in the population, women population, for simple problems also, like maybe a recurrent repeated episodes of leukorrhea or irregular menstrual cycles, some problems related like menorrhagia in the childbearing period. After finishing the family or after having 1 or 2 children, to every problem, they will think that the solution is to remove the uterus, to get rid of it. But this is not a good thing to be done for the women, because a lot of complications they will have to handle in their further life. Every one of you know. But what we can do to protect the uterus is this will help in diagnosing the pre-malignant lesions, which does not require any hysterectomy, and pre-malignant lesions possibility of progressing to the cervical cancer is very less. So we can take the help of this investigative parameter to identify at the earliest the pre-malignant lesions and extend the Ayurvedic science, whatever the medications available, whatever the modalities available, to make the women free of this cervical cancer. So if you can see the WHO statistics, every 1 hour, 400 women are dying of this cervical cancer. And the most important thing everyone has to remember is there is a very long latent period for developing the actual cancer from pre-malignant lesions. So this long period we can utilize to diagnose, but still we are failing. Cervical cancer is the only cancer which has such a long latent period. Any rest of the cancers, they will present only when there is almost advanced metastasis, etc. are present. But this is not such type of cancer which will give a lot of latent period to save the patient and also the most valuable uterus. What is needed is a simple visible examination with naked eye. So it may be a visual inspection, it may be a pap smear, or it may be a colposcopy, whatever it is. Yearly once, every woman who is sexually active has to undergo this procedure. So this simple test will help them to see whether they are having any changes in the cervix which can lead to malignancy in future. So this simple test will help many female, but in spite of that, every 1 hour, 400 women are dying with cervical cancer. So you can see what is the burden of the cervical cancer on the society and what amount of responsibility as a gynecologist we have on our shoulders. So this presentation outline is like this: microscopic anatomy, introduction to premalignant lesions, colposcopy, and pathogenesis, Ayurvedic view, etc. So this is going to be the presentation outline. Microscopic anatomy to understand the basic, to know the changes in the cervical cells, to read this microscopic anatomy, to understand microscopic anatomy is very important, but I am not going to present in detail because all of you know very well, just only a brushing up of this microscopic anatomy of the cervix. So as all you know, squamous epithelium, the cervix is covered by two types of epithelium, squamous and columnar epithelium. You can see the pictures also. This is the arrangement of the layers like basement membrane, and the darker part you can see is the nucleus. And the rest of the portion is, as you know, this is a cytoplasm and this is the nucleus. So basically, we will know in the pap smear the changes in the ratio of this nucleus and the cytoplasm, and also the shape of the alteration of the cells, which is called as size and increase in number from basal to the superficial layer. We call it as dysplasia. That is irregularity or abnormality developing in the cervical cells. So this is a pattern of the cells that are present in the squamous epithelium, and the internal endocervical lining is what you call columnar epithelium, and meeting point if this columnar and squamous is considered as squamo-columnar junction. So this junction is very important because any pathology undergoes in this area only. And this and ectocervix, that is a squamous epithelium, stratified non-keratinizing glycogen containing squamous epithelium. It has multiple, see here the multiple layer of cells, and looks for the naked eye very pale pink in color. And this is because of this glycogen content only. Whatever the reagents we use on the cervix to read the abnormality, this is a helping factor or important factor, the glycogen containing epithelium. And there are a lot of changes in the postmenopausal period, like this cells in the squamous does not mature beyond parabasal layer. So this is a parabasal layer. So postmenopausal, generally this beyond you cannot see. That is why the complete squamocolumnar junction will be completely everted into the endocervical canal. So this is one disadvantage in the postmenopausal period to evaluate the cervix, because we cannot take the pap smear properly and we cannot even read the changes that are undergoing in the squamous and columnar epithelium. And very thin and atrophic squamous epithelium is present, very easily bruisable, and the petechial hemorrhages you can see, and very much prone for trauma. So these things will also make the errors in the pap smear. So this is a disadvantage in postmenopausal period. Columnar epithelium, that's endocervical canal lining. It contains, comparative to squamous, only single layer of cells with a dark staining nucleus and very cuboidal shape of cells. So it secretes abundant mucus, and this mucus is the factor that lubricates the cervix and vagina. And this is continuation in with the upper limit of the upper limit is continuation with the endometrial epithelium. And you can see some polypoidal growths, which are the localized proliferation of columnar epithelium. And most important point clinically, and which is useful for the evaluation, is it does not produce glycogen, or it does not contain glycogen. So whatever the reagents we are using does not react because of the absence of glycogen. So this later in the further slides, I'll give the importance, what is the importance of glycogen. So this is the cervix picture. You can see this is a transformation zone. This dotted lines, what you see here, is the original squamocolumnar junction. So generally what happens when the girl reaches to the adolescent age, puberty crosses, and reaching to childbearing age, this squamocolumnar junction slowly moves towards the ectocervix. So this, how it will be identified, how this development, that is the old squamocolumnar junction is, you can see some small crypts. Crypts is a small opening like glands present in the completely distal area. So this script opening, when you see with the naked eye, it is not possible. And the purpose of colposcopic examination is to magnify. That is a
Hello.
Hello, am I audible, Dr. Mayura? Hello,
Yes, ma'am. Yes, ma'am.
am I audible?
Yes, ma'am.
Yeah, Shelley has to share the screen once again. I think the connection is lost.
Yes, ma'am.
Okay, okay. Yeah, just give me a second. I'll share. Yeah, is it visible now?
Yes, ma'am.
Yeah, sorry for the interruption. I think the Wi-Fi connection has lost. Yeah, so this transformation zone is a major part which undergoes lot of changes pathologically pertaining to any dysplasia in the cells. And also there is another important process that take place, that is metaplasia. So squamous metaplasia is a normal physiological change that occurs in this area when during the childbearing period, this columnar epithelium, that is the endocervical lining, will get everted and travel towards the ectocervix. And due to the acid atmosphere of the vagina and due to the chronic irritation of sexual intercourse or any other reagents or whatever used for douching, etc., this will get very much inflamed, the exposed columnar epithelium, and also it will produce abundant secretions with the because of irritations, and slowly physiologically, even if you don't do anything also, the squamous epithelium starts replacing the columnar epithelium. So this process of replacement of the another epithelium by the nature epithelium is called as squamous metaplasia. So this squamous metaplasia, when it is a mature type, mature squamous epithelium means just you will not find any red color in this zone. Completely pale pink color it will turn. So that is a complete transformation of the epithelium. That is, it is mature squamous metaplasia. So if there is any color remaining like red and pink, red and pale pink color alternating in this area, that is immature squamous metaplasia. That is still it is under the process of getting converted. So this importance clinically, I'll tell you in the later slides. So relation of this squamocolumnar junction, this is junction with external os, depends upon the age of the women, hormonal status, birth trauma, pregnancy, etc. So it is very close to the external os in the childhood and perimenarche. And after puberty in the reproductive age, it will grow to away from the external os and under the influence of estrogen. And during this period only, the elongated cervical canal leads to eversion of columnar epithelium, what I have just explained, which is commonly called as ectopy, or previously it used to be called as erosion. So the SCG during reproductive years goes far away from this ectocervix. This is ectocervix far away. So this is the old squamocolumnar junction, and that will again move towards the ectocervix, which is a new squamocolumnar junction. And the area between new squamocolumnar junction and the old squamocolumnar junction is the transformation zone, which is the vulnerable part of developing dysplasia. So this is the actual picture of the cervix seen under the colposcope. You can see the squamous epithelium here. This is a metaplastic squamous epithelium because it has been replaced by columnar, and again the squamous is replacing the columnar epithelium. So you can see a difference of pale pink color. Okay. So this is a mature squamous metaplasia. You will not see any redness like this. So this is an immature part and this is a mature part. So this squamous epithelium is a clinically important when it gets keratinized. Keratinization means becoming very hardening of the tissue. Generally perimenopausal period you can see, or because of chronic inflammatory condition also, this keratinization you can see. So normally without keratinization, immature squamous metaplasia or mature one, without keratinization there is no risk for developing into the dysplasia. But once there is keratinization happening, then you can expect there may be possibility of displacement, dysplastic cells developing in the squamous metaplastic area, which can lead to the risk of cancer. Okay. So events that occur in squamous metaplasia is appearance of small round subcolumnar cells, which indicates the moved on epithelium, columnar epithelium, and the reserved cells, immature squamous epithelium, and this does not produce glycogen. So this is the importance what we have to keep in mind clinically. When the columnar epithelium, what you call commonly erosion or ectopy, moves towards the ectocervix and gives a red color, when you apply the important reagents for the diagnosis of dysplasia, that is the Leubol's iodine, particularly because of lack of glycogen, the acetic acid also will not act on the columnar epithelium. So you will not see any negative changes over this columnar epithelium because of this lack of glycogen. So that will not be helpful. You should be able to identify between whether it is columnar epithelium or some abnormal metaplastic epithelium. So this is about, already have explained the transformation zone. So the risk factors for developing the dysplasia is HPV 16 and 18. Out of all other numbers, HPV 16 and 18 are more important, which develop in the dysplasia. Early age exposure to sexual intercourse, having multiple partners, multiparity, long-term OCP use, smoking, and some infections, nutritional deficiency, etc. These are all very much highly risk factors for developing the cervical malignancies or dysplasia of the cervix. So there is a difference between premalignancy and malignancy, though both of them should not be used contemporarily. Lesion that is not itself malignant but has greater probability of becoming so than normal tissue is premalignant. So carcinogenesis, as you all know, it is a multi-step process. It evolved through series of intermediate lesions and which have a greater pre-malignant potential than one that preceded it. And at-risk cell population can be sampled for detection of early abnormality with a simple test, that is pap smear. So the common etiology predisposing factors is HPV virus, as I told you, multiple partners immunodeficiency condition, multiparity, etc. So chronic persistent stimulus, it may be very early exposure to sexual intercourse or some infective origin leads to tissue damage, and the regeneration capacity depends upon the host immunity. So if the host immunity is compromised, definitely regeneration capacity of the cells will be reduced and can lead to the development of the dysplasia and lead to the development of invasive carcinoma. So hyperplasia is increase in number of cells in an organ or tissue. So this also happens in this cervical premalignant lesion development. Metaplasia, the difference between hyperplasia and metaplasia is reversible. Metaplasia is a reversible change with the replacement of one adult cell, that is, for example, columnar epithelium, by another adult cell, that is again squamous epithelium. So no change in phenotype of differentiated cells, that you cannot see any abnormality in size and shape, nothing will be seen. Dysplasia is disordered growth, loss of uniformity of individual cells, and their architectural orientation does not necessarily progress to carcinoma. So this is the most important thing. If any patient comes with a very anxiety seeing the report, there is dysplasia, you need not get tensed, because dysplasia does not indicate that it may progress to carcinoma. CA cervix was leading cause of death, as the statistics are indicating, and reduced by two-thirds due to the increased detection rate of precancerous lesions and the pap test, improved colposcopy and biopsy techniques. So there is a place in Maharashtra, that is Barshi. This is one great example for screening out the patient population, women population, and making the complete area free of cervical cancer with the help of Tata. So in Australia also you can see the same scenario. You cannot find any women now with the abnormal, even dysplasia also leaving cervical cancer, because that type of screening test they have conducted to make the society cervical cancer free. So majority of CA cervix preceded by precancerous lesions, and it exists as long as 20 years. So we have got a plenty of time if we do the screening test properly. Shedding abnormal cells do not invariably progress to invasive CA, but risk raises with the severity of lesion. For example, when it is early lesion, low-grade lesion, which is called CIN1, the probability is only 50%. When there is a moderate, that is LSI, low-grade lesion, that is CIN2, it is progress is more than 75%. And when it is a high-grade HSIL lesion, when associated with the high-risk HPV, the progress of going to cancer is very high, almost near to 90%. So in this long phase of pre-invasive disease, the events that happen is initially atypical transformation of the cells, followed by complete abnormal transformation, that is dysplasia, and developing into cervical intraepithelial neoplasia, that is low grade or high grade depending upon the condition. So HPV infection is a leading etiological agent. So nowadays you can also see the vaccine which has come for cervical cancer, but long-term studies are still pending for this cervical cancer vaccine. Virus-induced oncogenesis is due to interaction between virus oncoproteins and tumor suppressor host genes. So you can see some of the abnormal conditions like abnormal squamous, undetermined origin cells, CIN, that is cervical intraepithelial neoplasia, and cervical intraepithelial condition, carcinoma in situ also, you can see, which are considered as premalignant lesions. And the cofactors of progress. So what are the other factors which can help other than the host immunity to take the premalignant lesion to malignancy? The HPV type immunosuppression, sexual exposure continuous with multiple partners, steroid hormone taking, smoking, These are the co-risk factors. And progression rate is CIN1, that is low-grade lesion, is in the 10% it can progress to CIN1 to 3, and CIN2 to 3, the progression rate is 20%, and 12% of CIN3 is invasive. They can progress to invasive. So with this effective screening, we can reduce this percentage and we can reduce the complete transformation into the malignancy. And the glandular, that is columnar epithelium changes, cervical glandular intraepithelial neoplasia coexist with the squamous this abnormality. So always whenever we take a smear, both we should be make it sure that the smear should consist of both ectocervical and endocervical cells. So this is a pattern of triggering the pathogenesis of cervical neoplasia, sexual activity triggering the actual factor, and HPV exposure. The normal glycogen containing mature squamous metaplastic epithelium can get keratinized or can invite the infectious origin, and infection with oncogenic HPV types starts developing atypical or dysplastic squamous epithelium, and this happens in the cervical transformation zone. So that can be changed into squamous differentiation or endocervical columnar differentiation. Both, that is ecto and endocervical, both can happen in the abnormality. So these are called squamous intraepithelial lesion is low grade, high and low risk HPV. When it is having high grade, high risk HPV will be there. That is always high grade lesions are carried with the risk of HPV. When it comes to the glandular, that is the columnar epithelium intraepithelial lesion, it is called adenocarcinoma in situ, and the risk factors or associated factors are HPV 16, 18 and 45 as the high risk group. So this is invasive carcinoma development into adenocarcinoma, but it is a very rare rather than the ectocervical origin, rare in low grade and very high in high grade. That is when associated with smoking, etc. risk factors, it is more probability of developing intraepithelial neoplasm of glandular epithelium to adenocarcinoma. So the terminology what we see generally is when you do a pap smear, the report what we read is low grade lesions and high grade lesions. That is Bethesda classification. When you do a biopsy, when you take a piece of transformation zone for the histopathological examination, the moderate dysplasia of the cells is indicated as CIN1. That is cervical intraepithelial neoplasia, lower grade, and the cells involved is lower third. And when 2/3 of the cells are involved, we call it as CIN2, and it is a moderate condition. And when full thickness of the cell, that is complete from parabasal to the basal completely, it is involved, it is CIN3, and severe dysplasia, and it is also called as carcinoma in situ. It is a high grade lesion, but still we cannot call it as malignancy. After this only it can lead to the invasive carcinoma. So the characteristics of dysplastic cells, how can you identify the characters? So enlarged nuclei, in the initial picture I have shown you one cytoplasm and nucleus ratio. So generally the nucleus will start increasing and occupying the whole cytoplasm. Decreasing cytoplasm you can see, and the intensity of the nuclear staining, the color will be more intense, and very higher nuclear cytoplasmic ratio you can see, that is whole nucleus is occupied by the cytoplasm is occupied by the nucleus. The proportion of thickness of epithelium showing undifferentiated cells is used for grading. Already I have seen in the another picture. So now you can see in this intraepithelial neoplasia, this is a regular arrangement of maturation. This is a basal cell layer. This is a normal picture. So you can see the nucleus and the cytoplasm white color portion you can see here. But when it comes to the atypical, that is which are changing into abnormal picture, a very enlarged hyperchromatic nucleus you can see. The dark color increased in size nucleus, and the cytoplasm, that is the white portion, is reducing. So this is a CIN1 picture. So you can see CIN2 further increase of the nucleus and very deep, intense color of the nucleus compared to the cytoplasm. And the nucleus cytoplasm ratio is totally increased in this. And 3, you can see complete loss of differentiation with atypical cell in all layers of epithelium. You don't know which is parabasal, which is basal. Here, everything is looking alike with a very bigger nucleus. So this is more advanced grade, that is CIN3 carcinoma in situ. So you can see in this picture very clearly the cervical cytology pap smear pictures. This is normal. This is a nucleus. This is cytoplasm. This is a differentiation or arrangement of the cell pattern. So you can see CIN1, very intense clogging of the nucleus together. You can see, but still you can see moderate amount of cytoplasm. In CIN2, you can see the cytoplasm is totally decreasing and the nucleus is increasing and occupying the whole portion of the cytoplasm. And CIN3, all cells are alike. There is no differentiation and no differencing of the cytoplasm and the nucleus. So from here to here, you can see the difference in the cell pattern. So this is read in the pap smear, that is smear cytology. So what are the standard diagnostic parameters for identifying the pre-malignant lesion? The best and easy cost-effective source is pap smear, but still pap smear has to be read or studied by a pathologist. Another method, very cheap and best method, universally accepted, and the WHO also accepted, that is visual inspection of acetic acid, visual inspection with the leugolzidine. You need not have any instrument like colposcopy. Simply you can see with a naked eye by applying these agents. And next, finally, to confirm whether your finding with the naked eye is really having any abnormality, you should go for a colposcopic guided biopsy. So even the FOXI and ICOG recommendation is initially with acetic acid, VIA, VILI, PAP, HPV screening with DNA, and then finally colposcopy. So what we do in visual inspection with the acetic acid? So it will contain glacial acetic acid, 5% diluted in 95% of the distilled water. These are the instruments you require. Saline, normal saline with cotton. This is leugolzidine. This is acetic acid with cotton, and a spatula to take the pap smear, to visualize the cusco speculum, and to hold the cotton, one sponge holder. Am I audible and the screen is visible?
Yes, ma'am.
Please tell me if anything, because I'm hearing some sounds. I'm not able to identify whether the connection is lost. So this is a principle in using this acetic acid and leugolzidine is, when you use acetic acid, the abnormal proteins in the squamous epithelium will get coagulated. So that coagulation will give you the picture of a thickened epithelium with some dense white color. And when you use the leugolzidine, the principle is squamous epithelium, which is very glycogen rich. In the initial slides, I have told you the importance of glycogen. The glycogen rich squamous epithelium will make the iodine absorbed and stained in a very dark color. So it is a glycophilic agent, leugolzidine. So when you apply these agents, you can see a clear differentiation in the cervix. So you can use these two methods very easily. So in this picture, you can see this is a high-grade lesion picture, and the agent which is used initially is the acetic acid. We have applied acetic acid. So you can see there is a thick, white, dense area here after applying the acetic acid, and this is indicating the abnormality of the cell pattern. And even after the application of acetic acid, this is a transformation zone, what I was speaking. And these are the crypt openings, what I have showed initially in the slide. You can clearly see the crypt openings. This is with simple lighting and a speculum examination. Colposcopy is not done for this case. So you can see very clearly, even with simple lighting also, the crypts, opening of the crypts, transformation zone, very dense uptake of the acetic acid you can see, and very irregular pattern of the blood vessels. Okay, then you can see the same case with application of leukocytin. So this dark color, what you are seeing here is the normal uptake. That is we call it as a negative uptake. Negative uptake means there is no abnormality. When it is a positive uptake, this is the color. This is a brown color you can see, golden brown yellow we call. So this is the abnormal area. Now we need a colposcopy guided biopsy to take the tissue from here to send further. Now very clearly it is indicating it is a high grade lesion, but we should know what is the staging of that lesion. So we need a biopsy from this area. So the same case colposcopic report you can see. Same case colposcopic report, a very magnified. This is to visualize the blood vessels. We apply a simple procedure called green filter. So this is a light magnified with a green filter. You can see the abnormal pattern of the green filter is applied to see the blood vessel pattern. So you can see the abnormal blood vessels and very thick density area of acetovyte and leukocytin uptake, and also a polyp is present. So this histopathology report of the same case you can see is chronic non-specific cervicitis with CIN1 change. So we are expecting a high-grade lesion, but the biopsy report came as low-grade lesion, that is cervical intraepithelial neoplasia grade 1. And so that carrying of the CIN1 to malignancy is very less risky, and when the patient age is less, you can opt for a conservative management. In the later slides, I'll tell you what are the managements. So HPV, low risk cervical condyloma, CIN1. Higher risk group is 16 and 18, which leads to CIN2, 3. Intermediate risk is all grades of CIN with the HPV virus. So now coming to the colposcopic examination, why it is done and what is based for this colposcopic examination. What do you see in colposcopic examination other than in the naked eye what we see? So the first thing you have to see is color of the epithelium. Second point is surface contour of the epithelium. Arrangement of terminal vascular bed, that is the blood vessels, which I have told you it will be seen with green filter. And in this, the angioarchitecture, the pattern of the blood vessels and the intercapillary distance will be seen, and line of demarcation of the abnormality to the normal. So you can see this is a colposcopic picture, grade 1, very much shining and a thick transformation zone you can see, poorly defined without any fine. After applying acetic acid, you are not seeing any blood vessels here. Very poorly defined, very small vessels, finely caliber vessels you are seeing, and the intercapillary distance is also very less, and very flat white epithelium you can see with or without irregular pattern of caliber vessels. The blood vessels are not having much abnormality here. Some small blood vessels you can see, and this is the, you can very clearly see the color difference here and here, and contour is also not so irregular. So when this picture is seen on colposcopy, it is a grade 1 lesion or a low grade lesion. When it is a grade 2 lesion, now you can see the difference. The opacity is completely increased, the very thick acetovyte change, white color epithelium you can see, well-defined border you can see, and with larger caliber of the vessels. These are all the blood vessels you can see after the acetic acid application. Very larger caliber blood vessels, very distinguishingly you are seeing, and intercapillary distance is also increased here. And the flat white epithelium with irregular pattern of very coarse, these are the coarse irregular pattern of the blood vessels. So when this picture is found, it is grade 2 abnormality and completely abnormal blood vessel pattern in the higher grade lesions like CIN3. You can see like this. You can see the picture previous. This is not that much abnormal, but you can see here very much intercapillary. This is called bizarre of vessels. Very clearly seen like a pattern which is extending its roots. So this is abnormality, and this is the menopausal picture you can see. And this is the difference between because this is a very dense and very calibered vessels with irregular pattern. But here, this capillary picture, you can see very normal root-like spreading. So this is not an abnormality. This is menopausal change, but this is abnormality. So this should not get again confused. This type of tree pattern of the picture is not seen in the abnormal. This is most important picture, hyperkeratosis, what I was mentioning in the squamous metaplasia. When this type of keratinitis, this is not a picture after the acetic acid. Before applying acetic acid, if you see any thick, dense area like this, definitely under this area, there may be some abnormal changes. Usually it is benign only, but it can obscure the underlying changes. So all the patches observed before application of acetic acid should be taken for biopsy. So this is not a picture after acetic acid. Without acetic acid, this type of picture, even on naked eye over the cervix, if you see, you take out for the biopsy. This is the keratinized part of the metaplastic changes. So again, the same pictures of abnormality in the cytovite application. You can see different pictures in CIN1, CIN2, how it looks. This is all the after acetic acid application. So when you come to the modern management, for the CIN1, no treatment is required. Only some antioxidants are given in the allopathic signs, and just frequent screening yearly once is enough. But follow-up must be regular. If the patient is suffering with repeated attacks of leukorrhea, the conservative managements are loop excision therapy, cryotherapy, laser, cone biopsy, and finally hysterectomy. So this is the LEAP, that is large loop excision transformation zone. This is completely with this instrument. The transformation zone is excised, which is the major causative area of abnormal development of the cells. This will be completely removed. So the risk of progressing into cervical cancer will be more than 80%, it will be relieved. So the uterus can be preserved in an younger age group patients. So coming to the Ayurvedic need of approach in these different lesions, what we have found now, what is the importance of Ayurvedic intervention? 15% of women fail to clear the virus even after the LEAP surgery, whatever we are giving the conservative management, cryotherapy, etc. 15% of women, even after hysterectomy, it is found that 15% will fail to clear the HPV virus, leading to persistent infection. The inflammation plays a very critically important role in regulating the pathology of cervix, susceptibility to infection by virus like HPV and HIV, and it will decide the patient outcome. So these are the areas where we can intervene with our Ayurvedic management. Managing inflammation in these women to prevent disease progression, especially progression of cervical cancer, is a very much challenging for the existing conservative management. So we have to intervene with the Ayurvedic management. So you all know Arbuda is considered as neoplasia and Asadhya Vrana as malignant ulcers. So according to Shushruta, chronic irritation and
Hello, Vishala madam, can you hear me? Hello.
Hello? Hello?
हेलो यस मैम
Please share the.
मैम आपका जो पीपीटी है ना उसमें एक्सेस डिनाइड आ रहा है, हमें इधर खुल नहीं पा रहा है वो. वी आर ट्राइंग फ्रॉम आवर साइड.
Okay.
Just wait for a minute, but meantime you also try with your PC. Yes ma'am.
विशाला मैडम, आपके यहाँ पे एक पासवर्ड आया रहेगा एक्सेस देने के लिए, जरा आप बोलेंगे तो
हाँ,
फिर.
मोबाइल
जी.
पे आया. ओके
यस
ओके.
मैडम, देखिए ना जरा.
किस में? व्हाट्सएप में?
गूगल में, मेल में आया रहेगा.
मेल में आया. ओके ओके. Then there is, I have given a share option. I have done it. You just see. You have shared this file करके आ रहे. अभी ओपन हो रहे क्या आपको?
Yes ma'am. Just a second ma'am. We are trying.
Yeah, no problem. पासवर्ड ऐसा कुछ नहीं आया. शेयर द ऑप्शन करके आया.
प्रशांत सर, सर्व्हर रूम मध्ये कोण आहे का?
हा सर बोला.
सर, पूजा मॅडम ना ऍक्सेस द्या ना शेअर करायला, स्क्रीन शेअर करायला.
आहे ऍक्सेस त्यांना ऑलरेडी.
ओके पूजा, डायरेक्ट शेअर कर, तुला ऍक्सेस आहे बघ.
Ma'am,
Yeah.
visible ma'am. Slide is visible now.
Now, yeah, you go to the Ayurvedic management part. These are all finished now. I think.
Pooja, आगे.
Yeah. No, that's previous one. Yes.
स्लाइड शो मोड ऑन कर.
Yes, that's same. Now you please stop. So shall I start from here?
Yes ma'am.
Okay. So the terminology given in Ayurvedic science: Arbuda, neoplasia, Asadhya Vrana, malignant ulcer. So according to Shushruta, Mushti Praharadhi, that is irritation and trauma, may precipitate activate the formation of Arbuda. So this same pathogenesis is matching with the contemporary modern science. What is given? inflammation and irritation leads to the development of dysplasia. Next, please change the slide. Next slide. The invasive carcinoma cervix and the relation of asadhya artava dushti. You can see the features in artava asadhya artava dushti, that is Konupagandhi, which is emitting dead body smell, necrotic tissues with menorrhagia, and Grandhi Bhuta, etc. That is formation of big slough with clots. So this is, you can see this type of features in advanced CA cervix. That is food. Yeah, sorry. Yeah, you can see the feet. And the puti purulent discharges with putrid smell, mutra purisha gandhi, that is PV bleeding with urine and fecal odor. You can see in very advanced metastatic stage of vesicovaginal fistula and vesicorectal fistulas, etc. And the Sannipataja Ashrakdara also have the same features of this extraordinary condition of advanced CA cervix. And asadhya arbudas, which are considered as Tridoshaja, Mamsa arbuda, and Rakta arbuda. So these three can be considered as CA cervix, which are having the feature of fast growing muscular growth with continuous discharge of vitiated blood. So when we come to the premalignant lesions, we can consider Sannipataja Yoni Vyapad. So Sumsanatya Rasan Sarvan Dushayita Trayomata Yoni Garbhashayasta Swayor Yonin Yujyanti Lakshanahi. That is by consuming Patya Apatya Ahar. That is Apatya Ahar. The Tridosha situated in the Yoni and Garbhashaya gets vitiated or get into abnormal stage and produce native symptoms, that is whatever related to the particular dosha. And Daha, Shula, Shweta and Pichila Shrava of Pichila Artava, which is having the Shravata and Pichila form. So these type of symptoms are present in Sannipataja Yoni Vyapad, which we can see in the premalignant lesions. That is, whenever there is a dysplasia is seen, this type of symptoms generally patient will present. And according to Chakrapani, Anuruta Kala Artava, that is intermenstrual bleeding, is also a feature of Sannipatika Pradhara Rupa. So you can see in the premalignant lesions, sometimes with excessive immature squamous metaplastic conditions and severe inflammatory conditions, you can see sometimes intermenstrual spotting is present and characterized by mucosanguineous vaginal discharges. Whenever it is present with some abnormal dysplastic condition, you can see blood mixed with mucosanguineous discharges. And upadravas, that is Eda Apathyana Moolam Narya Gulma Arsha Pradhara Mishra. This is seen in the Charaka Chikitsa. So when this Sannipataja Yoni Vyapad is not cured, it is leading to the upadras, that is, it can lead to the pradhara, that is excessive bleeding, which is asadhya pradhara, means again we have to consider it as CA of the cervix. So Sannipataja is also incurable. Artava Dushti Nidana, when you see in the Rajaswala Paricharya, lot of factors are seen in the Artava Dushti, which is leading to the etiological factors of Artava. So according to Kashyapa also, Rutur Vyapadyate, whatever the Rutukala abnormalities or abnormal vihara the women do, that can lead to the premalignant lesions, that is Sannipataja Yoni Vyapad or Asadhya Sannipataja Yoni Vyapad. So when you see the Shatkriya Kalas, what is the condition that is happening in the premalignant lesion? Next slide. Next. So you can see, so please go to Shatkriya Kala versus premalignant lesion. Previous slide. Yes. So you can see the features of inflammation. That is, inflammation is a complex biological response of the body tissues to the harmful stimuli. So it may be pathogen, it may be a injured, damaged cell or irritant, and it is a protective response, inflammation, to make the isolation or restriction of the pathology to go ahead. And this inflammatory process involves the immune cells, blood vessels, and these act as a molecular mediators. So the function of inflammation is to eliminate the initial cause of cell injury and clear out necrotic cells and tissues. Next slide. Clear out the necrotic cells and tissues damaged from the original insult or original damage done, and the inflammatory process is to initiate the tissue repair. But if this is not properly being addressed, this can lead to the further damage. Next. So when you see the Kshatriya Kala involvement here, Vranashofa is described as Apurva Rupavastha of Grandhi or Vidradi. So Shotatastu Gatra Vivarne Shrita Te Sthana Dushayakriti Nama Bedat Aneka Sankhya Katichat Tesha Nidarshanardam Gadato Nibodha, according to Cheraka. That is, he has included Arbuda, Grandhi with Shota due to similarity in basic clinical features, that is swelling or protuberance, that is situated in different body parts. So tumor means swelling caused due to the inflammation, cyst, benign growths, etc. So we can relate here the Nidana factors, and the Samprapti of this Grandhi Vidradi can also be attributed to the development of the Arbuda, that is cancerous tumor. Also, as per the contemporary science, it grows rapidly and metastasizes. So these features you can also see in the Asadhya Arbuda, and also new blood vessel formation you can see, and this is all features you can see in the Arbuda development and Nidana of Grandhi and Vidradi. So Sanchaya Avastha is in the Kshatriya Kala stage of accumulation. So increase of doshas in their own sites, that is HPV, host cells, you can see metaplastic changes that is happening in the transformation zone, and that is limited to that particular transformation zone. But when it leads to the Prakopa Avastha, that is stage of aggravation, the accumulation of doshas in their own site is having the Prakopa or dysplasia. It is turning or changing the phase in its size, in its shape, very rapid mitotic division you can see. That is leading to the CIN1. And coming to the Prasara Avastha, stage of spread, that is hyperexcitation of doshas and spreading to the site of manifestation. That is the complete thickness of the epithelium is involved here, leading to CIN2 and 3. Then the Vyakti and Vedavasthas leading into the what you call development of actual malignancy can be seen. So this is the attribution of Kshatriya Kala in the development of pre-malignant lesion to the malignancy. So here we have to interfere in the development process before the Vedavastha. That is before at least at the Prakopa Avastha we have to interfere. Next. So the fundamental aim of Ayurvedic therapy is to restore the balance between the three major biological forces of the body, that is Tridosha, and any imbalance can lead to inflammation, which is Shofa Avastha, which can lead to the further complications. So basic principles of Ayurveda in the pathogenesis of neoplasia we can understand. Next slide. Midyahara Vihara. So it is disturbed, I think. So let me read it out. Midyahara Vihara, that is abnormal diet and lifestyle. Agnimandya, that is decreased digestive capacity. Dhatvagni Mandyata, tissue metabolism is affected. And Dhatu Poshana, utilization of nutrients by cells is also affected. Next slide. And which is leading to the Ama formation. Ama is nothing but the endotoxins, which leads to Tridosha Vikriti, or the imbalance in the biological forces, leading to loss of coordination or Sroto Vaigunya, and finally resulting into excessive metabolic crisis, resulting in the abnormal proliferation of the cells. Next slide. And the increased pitta at the cellular level can cause micro-inflammatory changes, and this disturbs the cellular components of the Agni. Next slide. Next. Yeah. Then the Tejas component of vitiated pitta enhances the metabolic activity of the cancerous cells. So vitiated kapha, so here pitta is responsible for the increasing the metabolic activity of cancerous cells, while kapha vitiated kapha responsible for abnormal growth of the tumors, and vata vitiation is responsible for the involvement of the process of metastasis. So this is a 3 doshas involvement. And these 3 doshas maintain equilibrium in the body. The general approach to this treatment protocol will be kindling of Datvagni Pachana, or eliminating the toxins, Shrotoshodhana and Lekana, that is scraping out the dysplastic cells. So now coming to the scope of Ayurvedic management, let us divide into 3: preventive, curative and palliative. In the preventive care, we have to start from Rajasvala Paricharya, then Sutika, then Shodhan Chikitsa. So the Rajasvala Paricharya, change the slide please. Mode of living during menstruation. There are some recent scientific statements that is helping avoid coitus. As per the Jeffcott gynecology, Orthodox Jews, they are very immune to cervical cancer because of the, they will never encourage coitus during the menstruation, and also they perform female circumcision also. So this will be helpful to the prevention of the cervical cancer, and Rajasvala Paricharya is very important in avoiding coitus, advising in avoiding the coitus during the Rajasvala. And avoiding coitus during menses, that is cervical epithelium is more vulnerable. That is why it is said to avoid. And frequency of coitus also increases the spermatozoa themselves act as carcinogens and with nucleic acids traveling to the cervical cells. So excessive indulgence in the coitus, which is also advised not to happen in Ayurveda, particularly during the Rajasvala time and also in other times. So this will be the causative factor: multiple sexual partners and excessive, very early exposure to the sexual coitus result into the damage with the nucleic acids to cervical cells because of the spermatozoa themselves acting as carcinogens. So this will prevent, these actions will make prevention of the development of pre-malignant lesions. When coming to Sutika Paricharya, during Sutika, what we can do to prevent the PML? So different school of thought like Charak, Sushrut, Vagbhat, etc. has given specific care for 6 weeks to 6 months. So the genetical constitution of the particular person, the living area has to be given due consideration. So more emphasis given to the introduction of the Ahara diet, mode of living, maintaining psychological harmony. So if this is not maintained, change the slide. It results into nearly 64 types of diseases of all systems, which are cured with very difficulty or either incurable. Displacement of genital organs, inflammatory condition of genital organs, menorrhagia, neoplastic growths, Raktagulma. These also are being the cause of improper Sutika Paricharya. So we can clearly understanding here the role and importance of Sutika Paricharya in preventing the pre-malignant lesions. Next slide. Combining all the thoughts, oil massage is, that is the Abhyanga, what we give is to pacify Vata, administration of Gruta or Sneha fats with Deepaniya Pachaniya Dravyas is, and Shodaka Dravyas eliminates the toxins, and also the Vatahara Kashayas orally will help in reducing the super excitation or hyper excitation of the Vata. And bath with the water boiled with the herbs having Vatahara property also kindle the Vata Prakopa. Next. And the Yavagu Manda, that is rice gruel with Gruta and Kshira, prepared with the Brahmaniya drugs, anabolic drugs for 0 to 7 days. And after 7 days, the Shali with the Mansarasa, meat soup. This is according to the strength and digestive capacity combined with Deepaniya Pachaniya Dravyas, which has to be given. And Sid's bath also helps to relieve the inflammation. And according to the living area, as per Kashyapa, these practices should be done because genetics play a lot of role in development of the dysplasia and malignancies. So this is also to be given a lot of importance. So how this process is, Sutika Paricharya is preventing is major factor that develop during the Sutika Apatya or Dosha Prakopa during Sutika Avastha is development of autoimmunity. So whatever the paricharya we are taking during Sutika Avastha, that will prevent the development of autoimmunity. Autoimmunity is finally having the probability of development of malignancies or dysplasias. So how these drugs and paricharya will help? This will act as a bioavailability enhancers, antidepressant and anti-stress, adaptogenic effect, ulcer healing property, antimicrobial activity, immunomodulatory, anti-tubercular, antioxidant, anti-diabetic, anti-inflammatory, anti-cancer. All these drugs, whatever we use and the paricharya we use, if you analyze, these are the properties we are going to get. And this will finally prevent the autoimmune status. So the rationality, next slide. The rationality is to restore the strength of the lady in the Sutika Avastha with systematic approach and not to burden the digestive system, immediate postpartum period, to bring back the body physiology and hemodynamics to normal state. So we saw with all this paricharya, this will happen, and it is directly helping to prevent the development of Raktagulma or pre-malignant or malignant lesions. So when you come to the curative part of this pre-malignant lesions, whether it is CIN 1, 2, 3, first biopurification with Vamana is very much needed. Yearly, just like how we do pap smear, yearly once Vaman Chikitsa has to be taken, and Ksarakarma over the keratinized squamous metaplasia, that has to be done, or persistent leukorrhea present with the abnormal columnar epithelium occupying the transformation zone, commonly called as non-responding ectopy. Cauterization or the Ksarakarma can be done, that is one sitting in 1 year. If it is repeating, we can repeat, but it is only one sitting. And Yoni Prekshalana, the purpose of Yoni Prekshalana with different type of Dhavana drugs, I need not say them or mention again. So generally for 7 days, at least once in 3 months, if we give yearly, that will reduce the acidic atmosphere of the vagina, and which will reduce the, simultaneously reduce the inflammatory reaction over the transformation zone, and will help to regress the pre-malignant lesion. And finally, the Yapana Basti yearly once has to be given. Next slide, because it is a Rasayana Basti. So it will help to prevent the further progression of the lesions into the CIN 2 and 3. So internally we can give Chandraprabhavati, Guduchi and Nisha Amlaki, because these are having potential immunomodulatory effect. So how the Ksarakarma acts? So Ksharana, Ksharanatva, Ksharaha, it is said, that is, it mobilizes, it peels off vitiated muscular growths, tumors, and the carbonates and hydroxide of the plant of the roots will help in happening this. So surgical, parasurgical procedures, Kshara is considered as superior. It has the function of Chedya, excision, Bedya, perforation, Lekya, scraping, Tridoshagna, eliminating pathogenesis. So these all properties are required to treat the pre-malignant lesions, particularly when it is a keratinized squamous metaplasia. This is important. So commonly used Kshara is Tankan Kshara and Apamarga. So these two are commonly used. Next slide. So the mode of action of Yapan Basti. Next slide, please. Dr. Pooja, please change the slide. Dr. Pooja, am I audible? Hello? Dr. Pooja?
Yes, ma'am, I'm doing it.
Yeah, please change the slide now. Dr. Pooja, please go to the next slide.
Ma'am, there is some technical issues. Just few minutes, ma'am. Sorry for inconvenience.
Yeah, otherwise, shall I start delivering? Nothing is to be seen there. So the next important part is Yapan Basti, that is a rectal administration of drugs that increases the absorption as it bypasses the enteric circulation. Direct absorption is promoted and it is having the immunomodulatory action. So which is a very important part of treating the premalignant lesions. It arrests the disease progression. And the Nisham, like what we give internally, the curcumin, lot of research has been done on curcumin. So you can see the research publications on AGTCAM also. So this curcumin is a natural phytochemical with potent anti-neoplastic properties, including modulation of P53 targeting. This P53 is a major agent in promoting malignancy. So targeting P53 activity has been suggested as an important strategy in cancer therapy. The purpose of this study was to describe a mechanism by which curcumin restores P53 levels in human cancer lines. So this study has been taken anti-tumor activity of 4 Ayurvedic herbs in Dalton lymphoma, ascites, bearing mice, and the short-term in vitro cytotoxicity on DLA cell line. So in this, these properties of curcumin is advised, so which is very much helpful in preventing not only premalignancy, but to increase the quality of life. When invasive carcinoma is there, you can also use it in use this as an immunomodulator. Next slide. It is also having anti-inflammatory, immunomodulatory, hepatoprotective, antimicrobial, antioxidant, anti-carcinogenic, so many properties which will also help to increase the quality of life in CS cervix. So these are some of the colposcopic pictures which were taken. One case of changing with the Kshara treatment. This is the first CIN2 condition. You can see the Lugol's iodine uptake completely positive here with a very bright mahogany brown color. But after 5 or 6 months of therapy, it is changed to a very reduced, that is almost 50% is reduced. So in this is in that after again 1 more month, this is almost indicating a normal transformation zone. This is a squamocolumnar junction. Here this color will be there. You can see normal complete transformation zone has taken up the negative positive iodine uptake. So this is indicating that there is no existing abnormality. So this is colposcopic evaluation of the pictures with the treated with the Ksharakharma. So here also you can see the complete normalization of the after application of Kshara. So this is the last one is this is the invasive cancer. So you can see a typical cauliflower growth, which is profusely bleeding. So this we cannot intervene anything with our treatment. This is CIN3. You can see oyster pearl. This is called oyster pearl color. Next picture. Yeah. This is, yeah, please stay on that. This is oyster pearl color. Very clearly, you can see very dense aceto white CIN3. It's very thick mahogany brown. You can see the same picture. And the same patient, which was not underwent any therapy after advising, came with invasive carcinoma after 1 year. At this stage, treatment was advised, but see how fast it went into invasive carcinoma within 1 year period. So coming to the palliative treatment, what we can do in established CS cervix cases, some drugs like Pata, Trayushna, Vrikshaka, these Quatapana will help in reducing the bleeding episode and some increasing the quality of life. And one of the patient, which is not treated by us, but somewhere remote patient, she survived with CS cervix without any surgical treatment for 20 years. But she said that she used to take daily Gomutra. So we have to explore the importance of Gomutra in treating the cancer. And Triflaquata Yonidavan will help in reducing some amount of excessive shedding, that is the excessive bleeding. It may help in decreasing the discharges and some foul smelling discharges with Yonidavana. That can be helpful. And Chandanaquata internally will also reduce the a typical burning sensation, etc. in the pelvic area. Because of this metastatic condition, patient will feel a little bit of relief. So this is about the today's presentation. Once again, thank you one and all for the patient listening, and I'm very sorry for in between disconnecting of the internet. But hopefully all of you got the essence of the presentation. Once again, I'm thankful to the BD Pol President and Dean Sir and HOD Madam Dr. Seema Meher and all other associated APs and the PG scholars and all who have attended today's webinar. I'm very much thankful all of you for making me allowed to share my views on this topic. Thank you. Any queries, please carry forward.
Thank you so much, ma'am, for such an explanatory lecture. Brilliantly explained every aspect. It would be very helpful for all of us. Thank you once again, ma'am. Now let's begin with question and answer session. There is a first question. What is digital video colposcopy? Please, ma'am, can you
see, colposcope is an instrument which has a magnifying lens in it. So it will help in video recording also. You can see the magnifying picture along with the video recording in the digital colposcopy. You can do simultaneous video recording. And it is that machine is electronically programmed.
Hello.
Yes.
Yes, ma'am. Is it all? Ma'am, next question is from Dr. Seema Meher, ma'am.
Can you hear me?
Yeah, yes, madam. Yeah.
I just wanted some elaboration on the Yapanabasti which were describing. Any particular drug you are using in that, or?
Sorry, madam.
I wanted more elaboration on Yapanabasti.
Yeah, the purpose of giving Yapanabasti in prevention of progression of premalignant to malignancy is immunomodulatory, that is Rasayana effect. So Mustad Yapanabasti will be beneficial. And Dashmul Yapanabasti also you can give. It also helps as anti-inflammatory. Any Yapanabasti you can use. That's not a drug is not much important here. But the other preparation what we give and the mode what we give in the Yapanabasti, that is important, the proportion. So Dashmul is also acceptable, Musta also acceptable.
Okay, thank you, ma'am.
Yes, ma'am. There is a next question from Dr. Sameer Gholab, sir. Please explain the role of HPV vaccine in prevention of CS cervix. Suitable age for inhalation.
See, it has to be started ideally by the age of 9 years, and if not, at least before the first sexual course exposure. But see that I think I'm not a person to comment anything negatively over HPV vaccine, because now it is propagated by the Foxy widely, but long-term studies we have not seen till now. But definitely the manufacturers and the Foxy is claiming that it will help in preventing particularly 16 and 18 HPV virus. So rather than going for that vaccine, which is not having a proper outcome studies, Sadvrutta following if we advise, that will be, I think, as per Ayurveda, more suitable.
Okay, ma'am. Okay, ma'am. Thank you so much, ma'am. There's the next question. There is next question. Every patient attending OPD should be advised pap smear or colposcopy.
No, colposcopy everyone cannot have, and it needs at least basic training to use colposcopy. So PAP and visual inspection, what I have told with acetic acid and leukocidin, these three are ideal. So you can take the PAP smear and you can do simultaneously visual inspection with the acetic acid and leukocidin. And the important thing is to be done is whenever you do a PAP, you should not subject the lady before for any douching, any PV examination, and even before night sexual intercourse. So without using any agent, just take the smear. When you are taking the ectocervix, rotate completely the spatula 360 degrees, and we are going into endocervix only half the circle, that is 180 degrees, because it will start bleeding and it will obscure the result. So mid of the menstrual cycle, the best time to take the PAP. And after taking the PAP and preparing the slide, same sitting you can do, apply acetic acid and leukocidin. So single sitting 3 can be done. And for all the low resource settings, this is ideal.
Okay, thank you, ma'am. There is another question. Role of any evidence-based Sthanik Chikitsa and its therapeutic evaluation. Since you have a vast experience of treating such patients.
Yeah, there are some studies done in, I think, in Mumbai only, Sayan College. One publication is there on Sthanik Chikitsa and immunomodulator drugs in CIN1. But limited, what we have is limited case reports, because the reason for that is major problem what you encounter is once if we announce the pre-malignant lesion, that is there is a change in the cervix when the family is completed, generally the people will prefer, particularly in the rural area, the women will prefer to go for hysterectomy. So exploring the probability of Ayurvedic role in this has still remaining as a theoretical concept only. We are definitely doing in some cases who are really reluctant to go for hysterectomy and who can understand the importance of this preserving the uterus, and there is no fear of going progression of this CIN1, then we can adopt the treatment. But it is convincing the people is a little bit difficult. That is why much of the studies are not there. Dr. Asha Sridhar is working on this, and Dr. I think Sujata Jagtap, madam. These two people are working on this pre-malignant lesions, and they have gone for some publications also. You can go through in Google. Asha Sridhar, madam, she's a HOD of Trivandrum College, and Sujata Jagtap, madam, I think from Sayan College only. Yeah.
Thank you, ma'am. Now, I request Dr. Mayura, ma'am, to please summarize today's session. Over to you, ma'am.
Thank you, madam. It was a wonderful knowledge feast for all of us. As all of us know, cervix is a fibromuscular lower part of the uterus, and it has got a sternocolunar junction, which is shifting its place from age to age physiologically, which is called as metaplasia. When this normal course gets a pathological mode, some atypical irregular sized cells of different shapes with large nucleus, perinuclear halo, etc., they develop, and this phase is called dysplasia. Starting from here, a series of changes happen in these cells to progress into CIN, which is the precancerous pre-invasive phase, and this CIN progresses into CIS, that is cancer in situ. And India has the largest, highest rates of cervical cancer sufferers. So thorough screening for effective early detection matters a lot. So stepwise detection of this precancerous stage has 3 methods. That is, first is cytology by pap smearing or liquid-based cytology. Second step is what madam has explained till now, that is colposcopy, using a low-power stereoscopic microscope with powerful light source to study this SCJ, and the transformation zone and exact zone for punch biopsy is noted with the help of colposcopy. And lastly, the histopathology, that is biopsy is taken and then studied for grades of CIN. Hence, colposcopy plays a vital role in this diagnosis. And the treatment includes two methods, as Madam explained, ablative therapy and excisional therapy. When diagnosed early, we, the Ayurveda torchbearers, can join our hands in treating such cases by using different oral medicine combinations, which includes ashwagandha, shunti, or even the dashmula, and even shatavari, which have antioxidant, anti-inflammatory actions, which are helpful for Vranaropana and healing properties, which also provide immunomodulatory and cytoprotective actions. So we have plenty of Ayurvedic such drugs which are very helpful for treating this pre-invasive, pre-cancerous stage. Also certain local treatments like Madam highlighted, Yoni Prakshalan, Pichu, Varti, and even the usage of Gomutra are very effective in controlling further progress of this dysplasia lesions into CIN as per Madam's experience. So Madam, with her extensive experience, has guided us today regarding the management of this condition by the usage of Ayurvedic drugs and different procedures. So we all are very thankful to her for such an enlightening session. Thanks a lot again, ma'am. Now I hand over to Dr. Meenakshi to continue with the further proceedings.
Thank you, ma'am. Now request Dr. Mangesh Patil, sir, Associate Professor of Prasuti Tantra and Stree Rog Department, to give vote of thanks. Over to you.
Thank you very much, Dr. Meenakshi. And it gives me immense pleasure to participate in this webinar and to conduct vote of thanks. So this is my responsibility to thank everyone. And we start with respected Dr. Vishala Madam. Dr. Vishala Madam, thank you very much for accepting the invitation and to deliver lecture in this webinar and enlighten us with your vast knowledge on the colposcopy and its uses and correlation with the Ayurvedic text. So thank you very much once again, Dr. Vishala Madam, to draw some time for us from your busy schedule. Thank you very much. I also thanks from my heart to Dr. GD Paul sir, who is chairman, our secretary, Mrs. Kalpana Paul Madam, and all the trustees, Rishi Paul sir, Kimaya Paul Madam, and Kavita Paul Madam, for continuous support us for conducting webinars and seminars, and also our beloved principal, Dr. Sanjeev Yadav sir, and vice principal, Dr. Nina Sate sir, for their continuous encouragement for academic well-being. I also thanks sincerely all the faculties who participated in this webinar for a great success, and also our HOD, Dr. Seema Mere Madam, to initiate this webinar. Also very sincerely thankful to all the PG students who really work hard for making this event very successful. And last but not the least, not a last, but our sincere thanks to our server team, Mr. Prashant sir and all his team members, to support us with the technical support. And lastly, I am sincerely thankful to all the participants, UG students, practitioners, and faculty members from all other colleges from Maharashtra and out of Maharashtra to participate in this webinar and make this webinar a successful event. Thank you very much. And I